to you all. This is the second of our GECO meetings, and it's a double header on upper GI tract and endoscopy topics. You had Professor Marfentimer last week on H. pylori, and this week, if you've been in the waiting room, you'll see what's on the agenda. We hope that the format this week will be more in line with how we see the meetings going forward, with a talk and then case-based presentations. The idea going forward is that we're going to help you with the management of your cases rather than us providing the case, as is the situation here. So what I'm going to do is I'm going to start with my talk, and we'll just move on from there. If you have any questions, you can please post them in the chat and we will try and speak to them. But we hope to make this session interactive, as you will see as we go along. So it's really my task to relay basically my 20-year interest in initiatives to improve training in endoscopy through my links with UCT, the Gastro Foundation, the World Gastroenterology Organization, African Middle East Regional Association, and now GECO and the WEO. I've tied hands with almost everybody to try and improve aspects of endoscopy training in South Africa and in Africa. First, I hope to touch on some of the background to CRC in Africa, and then move on to talk about colonoscopy, training principles, and what data we do have regarding cancer and precancerous lesions, and potential steps we can take, hopefully, going forward. This is the map showing the incidence of colon cancer. And you can see generally where the colon cancer is sitting in the Northern Hemisphere, and then more in Australia, New Zealand particularly, and again in the Americas, but more predominantly in North America. And essentially, they have about 3 times to 4 times the incidence, even higher, in the high-income countries in Europe and North America than we do in South Africa. And you can see all the various representations here. And again, that's based on data that we do have. Unfortunately, these are the countries that you can see here that are without really decent data. And it's a significant number of the, I think, 48 countries on the continent that we really know nothing about the frequency of colorectal data. So we must bear that in mind as we go forward. This is some data from a paper that's a few years old now, but I think it's the best data that we've had. And you can see here that we really do have more of a problem in Southern Africa, and most of that data comes from South Africa. And it's about 3 times higher than the incidence in Eastern, Western, and Central Africa. But when you compare it to the incidence in the UK, it's about 5 to 10-fold less. So that's the sort of magnitude of the difference in colorectal cancer that is evident from what data we do have. This is from the same article, and it again, this illustrates the variation in cancer between the different ethnic groups that are in South Africa. And again, you can see that as far as we know from this data set, that obviously the white incidence is about 25 per 100,000, which is very much in keeping with the incidence in Europe and the UK. However, there is some evidence to say that we are on a different trajectory for Africa. And this is Zimbabwean data, and I'm not sure if Leo is online, but Leo was a fellow with us and did his PhD on colorectal cancer in Zimbabwe. He published no fewer, I think, than 7 papers to do with various aspects of colorectal cancer. And one of them was this monitoring of the increase in colorectal cancer. And you can see over 2 decades, it's almost doubled. And again, now it's looking like it's half the frequency as it is in the European countries with a high incidence. The other thing about colorectal cancer in Africa is that the prognosis is really abysmal. And we really are still well below what the United Kingdom was in the 1970s, and by no means anywhere near what can be achieved, around a 60% cure rate, essentially, for colorectal cancer in the United States and most European countries that are not in the Eastern Bloc. So we have a long way to go, and we have a terrible prognosis with that. I'll show you some data on precancerous lesions, and this is data that we've gathered and Leo has put together. You can see there are 3 Southern African or Sub-Saharan nations that are represented here. And these are colonoscopy studies that have been done. 2 of them will recently be reported in the SAMJ in November. But you can see that our adenoma detection rate is around about 15%. But if you look at those in the ethnic black group, you can see that the adenoma detection rate is around 5%, with one exception, and that's in the private practice series in Johannesburg, where the incidence is 18.5%, much more akin to that is found in European series. So again, we can see that there is a potential for lifestyle changes within the Black African population that looks as though the trajectory of colorectal cancer is on the increase. I would like now to do a poll with you. You'll find in front of you in a minute, a screen will come up. And I'd just like to ask you, just to get some feel from the audience, exactly where we are with this. I would like you should now be able to vote. You will see something appearing on your screen now. Hopefully someone can confirm that that's happened. And we would like you just to tick what you feel so that we can get an idea as to where you are in terms of volume with your colonoscopies. I'll give you another 15 seconds to vote. You can all vote, and then we'll show you what the results of the poll are. Again, obviously, we may have a mixed audience of surgeons and surgeons who have specialist practices, or general physicians who maybe don't do procedures, but I think this might provide some interesting results. I'm going to close the poll there and share it with you, and you will see what we have found. Hopefully you can see that there is really quite a spectrum. In fact, it's evenly distributed between those. And I will show you some data that hopefully will explain the the minimum number of colonoscopies you probably need to do to become competent in colonoscopy. So I'm going to stop sharing the results and we will move on to the next slide. So that's a prerequisite to some data that I've got regarding colonoscopy performed in South Africa. And I was lucky to get some data from the Discovery Health Insurance Group, which covers 3.5 million of the insured population in South Africa, which is just approaching 9 million in total. And you can see this is their data from 2015 and 2019. And again, you can see the distribution of who's doing them. It's largely surgeons, and how many gastroenterologists perform a year, which from 2015 to 2019 is on the decline. And that if we look at the 2019 figures, we come to a sort of extrapolation. If you extrapolate their volume to the whole of the insured coverage of about 150,000 colonoscopies per year. If you take the uninsured population, which is about 51 million in South Africa, we've got some data from the Western Cape and also from KwaZulu-Natal that would suggest that for that population group, we're performing somewhere between 42 and 71,000 colonoscopies a year. Again, those are largely performed by surgeons because out with the 8 major teaching hospitals, there are very few gastroenterologists in the state sector. If you extrapolate these numbers, you will see that in South Africa, if all were insured, we would be doing just under 900,000 a year. If we were all uninsured, we would be doing less than 100,000. In United Kingdom, which has the same population as us approximately, we're very close to their population, they do 650,000 a year. So you can see the figures there. We have a 10-fold discrepancy in colonoscopies in the state sector, and we do about 200,000 more than they do in United Kingdom per head than in the private sector. So that's, I think, an equation that one should bear in mind as one goes forward. So in summary, CRC in Africa, the incidence is low, it's probably rising and poised to rise exponentially. The prognosis is poor, and colonoscopy capacity is certainly poor for the general population. And there are obvious intra-ethnic variations in precancerous adenomas. We can definitely say our data sets are poor. So what are the solutions? How can we improve colonoscopy? So I just want to raise another poll just now, and I'd like you to vote on this poll. And again, this leads into what we're just going to cover in a little minute. I'm going to launch the poll, and I'd like you to vote over the next 30 seconds or so. Hopefully you've got it now. That's great. I'll give another 5 seconds just to complete it, and then we'll get an answer where we sit. Hopefully you should be able to see this now. And again, you can see that at least 15% of you are honest, but that only 40% achieve greater than 90% cecal intubation rate, which I'll show you in a minute is what is considered the requirement for competency in most European countries. So what are the ways forward? Training, understanding what we call key performance indicators, which I will elaborate on because cecal intubation is one of them, what they mean and what we should do about them in our context, and perhaps how we can collect data. So we in Cape Town about 5 years ago, really after the results of going to UK to experience these training systems in action. But JAG evolved out of the screening for colonoscopy audit that showed that they had only a 55% cecal intubation rate. That's in the beginning of the 2000s. Again, they've developed about now, I think, 17 centres in UK where it's mandatory that all colonoscopists train and are re-credentialed if they are not up to scratch. And they have a trainee program that is utilised. And again, this is how that system works. So our exposure to it came when a few of us, Adam Bootle, Dion Levine, and Damon Bezos, whose dad obviously passed away in the past few days, we were all in Wolverhampton, and then we brought them to Cape Town, and we ran a training and train the trainers course here. And since then, we've been expanding those teachings and believe that it is the way that we should be trying to move forward with training in colonoscopy. I think it's important to say a few things about training in that that the trainee does not only have to develop the psychomotor skills to perform the technique, he has to acquire the knowledge and observational skills, which all need to be coalesced into real-time decision-making. This requires a variety of training methods, and he will move along the timeline of skills acquisition. We know that different trainees will progress at different rates, and that for a trainee to be considered competent, he will require approximately 250 colonoscopies. The JET system sets a minimum of supervised colonoscopies at 200. So no trainees in UK get signed off unless they've done 200. Having discussed the basics of modern training techniques, I will now move on to discuss how you assess quality in colonoscopy. These are the UK definitions for KPIs, and I'd just like to focus on bowel preparation, cecal intubation rate, withdrawal time, and adenoma detection rate. All these key performance indicators are interdependent. You can see here that they consider that a minimum of 100 colonoscopies is required to keep your competency up so that you can achieve these key performance indicators of cecal intubation of greater than 90, withdrawal time of probably nearer 10 minutes than 6 minutes. And again, the question of bowel preparation, which is a thorny question in certain of the countries that I've been visiting in Africa. Again, there are other things that are related to the comfort of the patient and other things, but time does not allow one to speak to those. And of course, what we're really trying to do is to prevent the post-colonoscopy colorectal cancer rate, which should be under 5.5% or 3.36% or 3.6% for screening. That means that your colonoscopies are not missing a significant number of cancers, and they are the final arbiter of quality, that metric. It's obviously something we have got no handle on in South Africa. I'd now just like to run another poll, and again we can see just where we sit with access to colon preparation. And I'd like you just to fill that in and tell us what you do use so that we can get some idea where you are and what you've got access to. And I'll close the poll there and we can have a look at see what's going on. You can see that most people, about half the audience, are using pegylated preparations and using the high volume. And again, yeah, there's still a reasonable amount of usage of sodium phosphate and laxative preparations, about 10%. Again, it would seem that a quarter of you are using the 2-liter preparations. I haven't talked to some of the other aspects of how you get good prep, but most places now are using 2 liters of preparation and using it in a split manner. So it is very important that you try and monitor whether you've got adequate preparation or inadequate preparation. And again, obviously, your task of getting to the cecum and finding things is greatly diminished if you have poor or inadequate preparation. So we believe that split preparation is the way to go, and we believe in pegylated preparation. Now I'd like to sort of move on to what we consider the landmarks. And here you can see the appendix orifice on the right and the ileocecal valve on the left. Again, this is the classical appearance. We've shown you a nice clean cecum. And of course, you must see the appendix orifice, otherwise you haven't seen the whole of the cecal pole. Seeing the ileocecal valve is just not good enough. And again, I'm going to run a short poll here, but I'd like you to look at this picture. You will see that there are three banks of pictures of the cecum. And I would like you to tell me whether the blue, the black, or the white bank shows pictures of the ileum. And again, I'll ask you to vote on that. This is quite fascinating. You obviously can't see what I can see yet, but I will share it with you in another few seconds. So I'll tell you the correct answer. These are pictures from a study. It's an anatomical study that was conducted about 4 years ago. And in fact, all these are pictures of the appendix orifice. All of them represent the appendix orifice. So you will see that it was potluck which one you guessed, but the classical appearance I'll show you in a minute is the one that we're used to, which is the ones you'll see in a minute. I'm just going to stop that. And you'll see the one that we recognize most is the curvilinear. We're very happy when we see it, and it's usually pretty easy to find. But the frequencies of these other ones is also are quite high, and this is a description that you can use. The reason I'm showing you this is that it is important to know if you reach the cecum or not. And it might be quite difficult on occasions to actually do that. So what should you do? You'll see here that I've got a Pentax and Olympus cameras. You can also use a Fuji camera, but whatever else you should do, you should be photo documenting that you've been to the cecum, and you should photo document any pathology you see. And obviously, if you're running multidisciplinary meetings for cancer or polyp removal, then you need to have these visual representations present at those MDTs. So I think it's, in this day and age, I think it's feasible, even in resource limited situations, to be able to do photo documentation. This is a system that we use in our clinic at Grooterschuur. And again, we can capture the images quite simply and import them in there. So we have a permanent record of the cancer or the polyp and exactly what we did with it. And also, obviously, for other inflammatory bowel disease and other conditions that affect the colon. So I think it's very important that we should document our findings, and photo documentation is now becoming mandatory, and you should be thinking of ways how to do it. I just come back to the data that I presented earlier, but here now I just want you to focus on the cecal intubation rate. And again, you can see there that in the recent studies, 2 of which were presented in abstract form at the recent SAGES meeting last year, but you can see that we are achieving CIRs that are really in keeping with those that we are meant to be achieving. And again, we're still finding out what the true adenoma detection rate are. Interestingly enough, there's very little being written about high-grade adenomas, which are the ones that are really important in terms of cancer detection at an early stage. So I'd just like to summarize here by, I think, this is the data that I think you should be keeping. You should be keeping your KPIs so you can monitor the progress of your trainees. And I think established colonoscopists in private practice need to be keeping this and also being able to produce it as evidence of competency. I think the cecal intubation rate is the key performance indicator. You have to get good quality bowel preparation, and it should be photo documented. Pathology metrics are really important. You need to be able to detect these lesions, send them for histology, and determine the true burden of disease so that you can inform healthcare policy. Access to high quality colonoscopy is limited in the state sector, I think in all countries in Africa. And from the figures in South Africa, there's definite need for expansion just to cover diagnostic needs. I think South African training centers can assist in South Africa and Sub-Saharan Africa to develop colonoscopy capacity and quality. And I think there is a need to set up databases for colonoscopy, standardize the data sets so we can start to get some information on how we can go forward with improving the colonoscopy service and the service to reduce and manage better colorectal cancer. With that, I think I'll stop and we can take any questions that have accrued from the chat, which hopefully you've been posting during my talk. Thank you. Has anybody posted any questions in the chat? So I have some questions here in the chat that I'll try and deal with. The first is, in UK, there's a minimum of 200 supervised colonoscopies for trainees? What would you say is a reasonable number in SA? That indeed is a good question, but I think in the training units where gastroenterologists are trained, I think it's possible that some degree of supervision is possible for the first 50 to 100, and some degree of group supervision is also present. And I think that is feasible. And again, we need to monitor that progress. I think some people do and can do it in fewer, but if you're trying to get to these aspirational goals, that's the average number that an average trainee would take. Surgeons always think that they're faster and quicker than physicians. There's no evidence really to suggest that they are, as far as I'm aware. There's another question from Mashiko Sachedi, the professor and head of unit. Is there enough data locally in blacks to start screening at the age of 45? Unfortunately, I didn't really touch on screening. I think that's a whole separate issue in its own right. I don't think we have the capacity to do that, but I think we should be looking at risk factors that might predispose individuals to be targets more for surveillance, which I would suggest is patients with familial syndromes, as the Lynch syndrome group in Cape Town under Paul Goldberg has been studying for years. It makes a big difference there if you screen. And I think what is really needed is a national data set for that. I think there may be other options other than colonoscopy for screening, but I think we've got a huge deficit in simply dealing with what we need for diagnostic purposes rather than screening. So I don't think screening is feasible. And I think one of the African dilemmas that I didn't allude to is the fact that the cancers, at least 30% of them are in under 40-year-olds. So I think the adenoma carcinoma sequence is not quite the same in Africans as it is in Caucasians. And I think we just don't have the evidence to do that. In Leo's series, he only identified out of about 100 specimens of colorectal cancer, I think 3 individuals who probably had a familial risk. So even though some of these cancers behave like familial cancers, we haven't yet identified what that characteristic is that's causing them to occur at a young age. So I think there are many bars to doing screening. So I don't know who David Linyama is, but how can we help? Well, I think this is a start in terms of what we're doing. But before COVID, we were visiting training centers in Africa. There's a WEO training center. There's a training center in Tanzania. There's one in Nigeria. And we've been visiting there, running training courses there. And I think there is scope for us to do that. And I think for individuals, you saw the range of colonoscopies that are being performed in that poll. And I think obviously we're way short of volume to train adequately. But I think for those individuals who have got some experience, there may be ways forward with telementoring from a distance. That means transmitting to, say, Cape Town, and we would help you, guide you through the procedure as you did it. But I think that's something for us to explore. There's certainly proof of concept for it in Western countries, but we've yet to set it up and successfully do it in Africa. But that is one possibility. I think that's all the questions that have come through on the chat. I hope that I did give you some information that was valuable and that will give you some food for thought. And now I'd like to hand over to Ed. He's going to present in a different fashion, and he's going to move on to something in the biliary tract. Ed, if you could take over and share your screen with the audience. Thanks.
Right, can you see my screen there?
Yes, I'm good.
Okay, so thank you very much, Sandie. So we're going to have a case, a slightly more surgical case, but also a scenario I think that we get confronted with regardless of whether we are surgeons or gastroenterologists or general physicians. This is really also, before we get there, I think not only sort of sharing our problems and our knowledge and to stimulate discussion, but also to get an idea what the capabilities are for treating different conditions. As Sandie's already pointed out, and we see those discrepancies in South Africa as well between the large cities and if you go out into the periphery, that equipment may be a problem, and the means that you've got there are much less than what you've got in the cities. And I think that's very important information. And there's a saying that says necessity is the mother of invention. And I think people have come up with very good ways of dealing with clinical situations when not all the equipment that we would like is around. So there's also going to be a poll in some of these questions. So Sandie's going to put up the poll because I can't multitask as well as he does. So just to start off, Sandie, if you just can get that poll up. Just if you just see to know whether you have got these following treatment modalities available. So if you've got ERCP available, PTC available, click on it if you've got none, if you've got both, just to get an idea. I think we have 50 on the dot participants now. So we're just over half there.
Yeah, I'll just give it another 5 seconds, and I think you'll find some interesting data. I'll share it now.
So just while Sandie is sharing, I saw that around 20% of the colleagues that are with us don't have any of those possibilities. If I remember correctly, about 40% have the possibilities, or both of them.
Ed, can you see the share, the actual poll results now?
No, I don't know.
Okay, let me just let me speak to them. So 56% have both, 18% have ERCP, 6% PTC, and 21% none.
Okay, so just under half of the colleagues. Oh, now I can see it there. Now it came up. So okay. Just about 50% or under 50% of the colleagues have got both of these available. I'm just going to share a case with you, a female 38 years old that actually presented at the hospital about 700 kilometers from where we are in Cape Town. The history was that she was otherwise well, no weight loss or constitutional symptoms. And then she presented with jaundice. On examination, she was clearly jaundice, otherwise no findings. And I've put the blood results for you there. You can see that she had an obstructive picture on the liver function tests, and the enzymes more or less matched that. And then the ultrasound was performed, and it showed stones in the gallbladder as well as dilated intrahepatic bile ducts. So just in your hospital, and it will be very interesting to get some opinions from the colleagues in the rest of sub-Saharan Africa. If you approach with a patient like that, in other words, you've got common bile duct stones in a jaundice patient, otherwise well, what would your approach to that be? So while Sandie gets it ready, so would you do a cholecystectomy and the bile duct exploration open? Would you do it laparoscopically? ERCP with stone removal, would you just put a stent in there to get rid of the jaundice and then do a cholecystectomy later with a bile duct exploration or a PTC drainage?
Yeah. the poll is running. I'll give it another 5 seconds and then I'll share it with everyone.
All right. So
have you got it now? Yeah.
I've got it here, and I think just about half of the participants answered here. Cholecystectomy and bile duct exploration open. There were 3 participants, and then most people would do an ERCP and they would remove the stone. I think that would stones, and that would probably be a good, good option. Cholecystectomy and bile duct exploration, laparoscopic, certainly something that we have to get better at. If I may just ask, Onosai Shiaka was a fellow with us in Cape Town. I see he's on. And he's trained in ERCP, but I know they've had quite some trouble to get the equipment sort of in place in Harare. Honestly, if you can sort of unmute and maybe just comment on that.
Okay, thank you very much. I hope you can hear me clearly.
Yeah, all good.
Good. Yes, thank you very much. Yeah, certainly, like you noted, we had a bit of a challenge getting ERCP system running. But I must report that at least in the private sector, we now have the capabilities of doing the ERCPs. So we can only do ERCP and stone removal only in the private patients who can afford it. Our state hospitals at the moment, we don't have the facility. So it's only available in private, and we have started doing them.
So in state, would this patient then undergo cholecystectomy with a bile duct exploration?
Yeah, certainly they will have to. We will do an open cholecystectomy with bile duct exploration here in the state, yes.
Okay. Thanks, Onosai. So this is what happened. In this hospital, they had ERCP capacity and I think some equipment to perform basic ERCPs. So they performed an ERCP, they cannulated successfully, they filled the biliary tree with contrast, demonstrating a very nice chain of stones in the common bile duct. I'll show you some pictures later. Then a sphincterotomy was performed, the balloon extraction was attempted, but without success. So at that point, the procedure was stopped and referred to our hospital. So I think one can sort of discuss that a little bit. And I was just wondering, Dr. Karan Gandhi, I saw he was on. I hope he still is because he's soon doing his exams. If he can tell us if he's got a problem with that management.
Yeah, I do have a problem with that management because this is someone who's had their biliary tree contaminated now by injection of contrast into the biliary tree. And there's no drainage procedure that's been performed. So for one, even if they couldn't proceed with the extraction of stones, they should have at least stented the patient and at least got drainage in the common bile duct so that the patient doesn't get cholangitic before referral.
Okay, I think that's a very good point. Thanks, Karan. So the patient, even if it was only 700 kilometers away, the transport is not always that good. So the patient arrived here 3 days later. At that stage, complaining of rigors and upper abdominal pain. The patient was still hemodynamically stable, but a clear infection was ongoing. The patient was deeply jaundiced, and there was tenderness over the right upper quadrant. And then with the blood results that I show you there, so white cell count raised, bilirubin even higher, and you can see where the enzymes have gone. So in terms of a diagnosis, I think there's not much of a discussion here. This patient has got a cholangitis, and in the interest of time, I'll just move on. And for the rest of this talk, I'm just going to sort of talk in terms of the management and also the current evidence and guidelines of the management of cholangitis, and refer to the Tokyo guidelines, the updated ones from 2018, where there's a very nice, the diagnostic criteria for cholangitis have been very well defined, and also a grading system for the severity of the disease. And for once, I think we've had guidelines that are not only aimed at the developed world or the high income countries where all treatment options are available, but also cater for situations that we often find in countries where we are not that well resourced in terms of equipment. Quite important. I mean, when it comes to cholangitis, we've always been talking about Charcot's triad in the diagnostic criteria, in using it for the diagnosis of acute cholangitis. But it's very important that the sensitivity, if we looked at the original Charcot's triad, was very low. It was in the region of about 25%. But already in the Tokyo guidelines of 2013, just dropping abdominal pain from the triad, the specificity already raised to 77%. So I think the message there is that Charcot's triad that we still teach the students, it's actually not a very good measure. And the way that cholangitis are diagnosed now, so as you see at the bottom of the slide there, we distinguish between suspected diagnosis and definite or definitive diagnosis. And you look at three aspects, quite easy to remember: systematic inflammation, either clinically or supported by laboratory evidence; cholestasis, clinical jaundice supported by laboratory evidence; and then biliary dilatation and evidence of some form of etiology. And if you've got item A and one of B or C, it's a suspected diagnosis. And if it's A, B, and C, you probably are spot on with the diagnosis. These are the criteria that are used. So for fever, more than 38, white cell count less than 4, more than 10, CRP raised above 10, or just abnormal bilirubin, as I show you there, and the enzymes 1.5 times the upper limit of normal. So at this stage, would you perform any imaging on this patient? So we know the patient has got common bile duct stones. The patient is cholangitic. Is there any sense for performing imaging? So you can just run that poll, Sandie. So the yays and the nays there. So far it looks like a 50-50 split to me, what I can see here. I think we can share there. There we go, yeah. So can I ask anybody that wanted to do more imaging to defend their opinion? Unfortunately, can't see who did, otherwise I would have asked somebody.
If you can unmute whoever wants to take on the challenge and just speak.
I see Colin Noel is on. Colin? Or is he off? No, he's still on. Colin, yeah.
Can you unmute?
Yeah, he's unmuted. But we can't hear him.
Prof, I think they might.
Oh, now I hear you.
Can you hear me, Prof?
Yes, hear you.
Oh, there we go. Sorry, there might be something wrong with my microphone. Prof, I think there are benefits to doing further imaging. I think the one thing to consider is that somebody has tried to do an ERCP and failed, and it depends on obviously depends on the technical abilities of the person who did it. But stone size would obviously make a bit of a difference with regards to management and the difficult extraction. So imaging could give you a bit of information with regards to stone size. And then obviously the other thing that imaging might assist with is complications. So subsequently, are there intrahepatic abscesses that have developed, and you probably wouldn't get that information, or you won't get that information from an ERCP if one didn't have further imaging. So I think it might add in the sense that you can anticipate a difficult ERCP and plan for that, or stone extraction and drainage. But yeah, apart from that, I can't see any other benefit for further imaging.
Oh, thanks a lot. I think that, there are certainly advantages and disadvantages here. I'll tell you what we did. But just briefly, regardless of which imaging you use, the benefits of imaging here is when you're looking for a diagnosis, obviously you can see dilatation, you may see the cause of the obstruction. There are some direct signs of cholangitis. I'm not going to go into that, but there is some CT and MRI findings that can actually indicate the presence of cholangitis or not in obstructive jaundice, maybe help us with the severity grading and complications, as you've mentioned. And regardless of what you use, I think all the imaging modalities we have may help you with that. As I said, with severity grading and direct signs of cholangitis, it's only CT and MRI. It's quite new, and some of them may be a little bit better than others. But I think the message there is you can use whatever you've got. So in this patient, and that's what we followed as well when she arrived. Initial management was to just stabilize her, make sure that she's well hydrated and check her kidney functions and so forth. She was started on antibiotics, and then biliary drainage was contemplated. So again, just a quick question here. At your institution, how would these patients be managed? So now we've got a cholangitic patient, and that is clearly not well, and we have to do something. So if we can poll that one, Sandie, and then I will again just ask on a side at their situation, not in private where they've got all the possibilities, but what they would do in the state.
Okay, thank you very much. Like I said earlier on, ERCP and PTC is really not available in the state. So I think the only option that we have for this patient after stabilization would be for immediate surgical decompression.
Okay.
Yeah, because we won't have access to the other two options there.
Okay, I think we can share, Sandie, we've shared already. Yeah, so you can see there that I think wherever ERCP was available, most people would have opted for ERCP. Certainly if you don't have ERCP, you don't have a choice. You probably have to go and perform surgery of these patients, and preferably clear the duct of stones as well. PTC, if you've got that available in a patient like that, could also be sort of a life-saving procedure. I'm going to pop over this one because we can quickly take that and just see what people say. Would you perform, sorry, no, Sandie, I'm just going to pop over this one and just move to the next one in the interest of time. So the previous one just asked the question, would you remove the stones or would you just opt for stenting or drainage? And I think that's also a very interesting point that we can discuss, but we're slowly running out of time here. Just when it comes to the severity grading, and I think this is quite important, and this is also in the Tokyo guidelines, because these patients we know can be from quite well with sort of a slight infection without constitutional symptoms to patients that are desperately ill. And you can see here the grading, and I like this classification for starting with a worse one at the top. So we grade cholangitis in 3 grades: grade 3, grade 2, grade 1. Grade 3 really is multi-organ failure, or one of the organ failures and the definitions thereof. And then grade 2 is the only one that you need to remember, because if you don't have organ failure and you don't have 2, you're a 1. So abnormal white cell count, high fever, older patients do worse. We know that. Higher bilirubin, and also a patient with hypoalbuminemia, that obviously gives an indication of their general condition, maybe feeding status, and also the way that they would heal after any procedure. And importantly, and that is emphasized over and over in these guidelines, it's not a once-off assessment. At the beginning, we don't know which way this patient is going to go. So if management hasn't been started yet, or only limited management, it should be reassessed and see where this patient is going. So when would you perform drainage in this particular patient? So this patient would fall in the grade 2 category. She hasn't got any organs failing at this time. So if we can poll that one, Sandie. So would you do it immediately? Would you do it within 24 hours? Will you do it within a week? Right, I think we can share there, Sandie. And there you see it. So most people said within 24 hours, almost 70%, and then about 25% immediately. And within a week, two of the colleagues said they would wait a week to do it. So these are what the guidelines say. So if you've got a grade 1, a very mild cholangitis, you will treat them medically, and if there's not a response within 24 hours, you will proceed with a biliary drainage procedure. If it's very severe, grade 3, that this patient is, you should go immediately. But then they also say in patients that are grade 2, if you have got the possibility, is to do it as soon as possible. But I think within 24 hours in this patient would have been a reasonable option or answer, because we do not always have the possibility to do it immediately. Just also very important, and this is very nice in these guidelines, because they realize that not all people have the ability, and there are even guidelines in terms of patient transport, when these patients should be transported, and it also depending on the capability at the unit. I'm not going to dwell on that. What we did for this patient was to do an ERCP, and I can show you there just some quick pictures from it. But basically, made the sphincterotomy a bit bigger, engaged first with a balloon and could pull out 1 or 2 of those quite large stones, had to crush a few, but eventually, as you can see here, with the balloon blown up in the common hepatic duct, the very nice clean distal bile duct with a nice tapering bile duct at the end there. I don't know if there's any discussion at this stage, but I think we'll just have to move on. Or at least rather say we have to move on because our time is about out. Just briefly, if you go into these articles describing the Tokyo guidelines, and I'm very happy to share any of those articles with anybody that can just mail me. I don't think they're in a journal that are not that available, and I don't think they're freely available, but I can supply them. So the whole algorithm that we've talked about is sort of summarized in this little diagram here, and also in terms of the grade and how treatment should be performed. There's an acute cholangitis bundle checklist that you can put in the patient folder and just tick the boxes to make sure that your management is up to scratch. And as I said, we'll get the imaging there. Ultrasound is also an imaging. That this can be performed even if you are in a very low resource environment. And then there's also a mobile app that you can put on your phone and stop this. And you can sort of refer to everything that we've said now there. Thank you very much. Any questions or any comments?
Let me just go to the chat. I don't know if anybody's posted anything in the chat. I think you did a comprehensive job of interacting during the procedure, so I'm not sure if you've left many questions unanswered.
It's Mesh here. May I ask a question?
Of course. Go ahead.
I was just wondering if, Ed, you did do a CT scan, and did it give you any additional information?
No, this patient went straight for ERCP. I think one can argue about that, but I mean, clearly this patient had a cholangitis, and the treatment of that would be at least draining the bile ducts. She was actually reasonably stable, so we did take out the stones as well. But an option here in an unstable patient could have been just to pop a stent past the stones, drain the biliary tree properly, and if you didn't have an ERCP, to put in a PTC, even if you can just get external drainage, so the catheter doesn't need to pass all the way to the duodenum, that would also be helpful. But as Onesai said earlier, there are centers where you don't have a choice and have to do what you can with what you've got available. And I think that is not only a situation, it's even a situation that our colleagues in the periphery in South Africa faces. that you sometimes have to just use what you have available to solve these problems. I see there are some
questions coming up. Just go through them, Ed.
Yeah. No, I think that was it.
I think the earlier ones are from colonoscopy.
Yeah.
Perhaps I know we're sort of at time, but I think it's.
Sorry, I just said there's a link to all the articles of the TG18. I didn't know that, and that is posted on the chat. Can everybody see that at the bottom there? Maybe just copy the link.
Yeah.
Great. I think we can also share it with the delegates afterwards. Karen will share.
So we are. If I can just say a couple of things that are for general information. The resources for this can be made available to you, and that's one of the purposes of this ECHO platform, is that we can do that. And this whole session today is recorded, and you will be able to access it through YouTube. So if we have your details, we can certainly do that. If there are aspects that you want to go back and have a look at, and as I say, the resources that we use, the talks, the slides, will all be posted on the ECHO platform, to which you will have access. So that's important. Okay, I just, again, sort of, this is a slightly different format from the format that we used last time. It was much more of a webinar come didactic lecture, and this is the format that we really would like to use. One of the things that we are interested in, and it's really encouraging that we've had 50 participants, but we are interested, especially those from outside the South Africa, that you let all your colleagues within your framework know. You can forward them the invite to these meetings, which will occur regularly. And if you are interested in sort of learning about the ECHO platform and being a champion for this type of format, then it is possible for you to enroll for what we call immersion exposure to ECHO, so that you get an idea of some of the technical aspects and some of the principles that are difficult to sort of expound in a meeting. And we would definitely be looking for volunteers for the next meeting in a month's time, for volunteers to present a case similar to Ed. And again, you can design the interaction, but obviously we would ensure that there's expertise related to that case that would be available at the meeting and to advise you. And again, we would then summarize that management algorithm or plan for you as the way that we would hopefully guide you to manage the patient that you were having difficulty with. So that is the essence of what we want to try and do going forward. And as I say, this is a partnership to some extent with the WEO. So some of the talks that we will be doing as the first part of the meeting in the endoscopy GI session will come from world leaders in their fields. And again, those will come out in the invites that you will receive.
Sandie, yeah.
Yes, please. I think I've said enough just now. Please.
Yeah, just briefly. So just a reminder that next week, that this is a weekly meeting, although the topics do change. So endoscopy will be on in a month again, and that the next meeting, as you see there, is IBD, and the moderators are going to be Mashiko and Joel. So please attend. And then also just to thank all the participants from today, and specifically also Cheryl and Karen, that's doing all the grinding behind making these meetings work. Thank you very much. So that's all from me, Sandie. I don't know if there's anything more you want to say.
If I can, I think we we also must, again, as we said last week, we're hosted through the Indian aspect of ECHO. Originally, it was centered in New Mexico, but our affiliation and our relationship and all our sort of technical support is coming from them. They are again online with us today, and one would like to thank them very much for doing that and participating and helping us to get these initial meetings off the line. But I think that's all I need to add. I think we've said everything. And as I say, this is your meeting. We want you to participate and let us know in the feedback how we're doing and how maybe things can be restructured so that we can help you more. So thanks very much, everybody, for attending. And I think we can call the meeting to a close now. Thank you.
Thanks.
Thanks.